Hi, everyone. It's great to see you. Today, we're going to be talking about what causes inflammatory bowel disease. And as I mentioned earlier, a lot of what I talk about today for inflammatory bowel disease is generally applicable to other autoimmune diseases. So I'm going to talk about sort of theory of how autoimmune diseases develop, and then hone in a little bit on inflammatory bowel disease, on Crohn's disease and ulcerative colitis. So the first thing that I want to tell you is that autoimmune diseases are really common. About 1 in 4 Americans, the number somewhere north of 50 million Americans have an autoimmune disease. I have a couple. I have some eczema, and I also have Raynaud's phenomena, 2 minor ones, but still, the list of autoimmune diseases were up to just a little over 100 autoimmune diseases. So think about, from a bowel point of view, we have Crohn's, we have ulcerative colitis, we have celiac disease, we have autoimmune hepatitis. We have more generally systemic autoimmune diseases. We have diabetes. We have things that affect the joints like rheumatoid arthritis, sacroiliitis. We have MS. We have lupus. We have Sjogren's, and we have tons and tons. We have ones that affect the skin, eczema, psoriasis, etc. So we have more sort of rare, unusual ones, and we have really common ones that affect a large percentage of the population. And so one of the things that, I really want you to think about is, where do these diseases come from? They're what a lot of people call modern plagues, because we really started to see a huge increase in these autoimmune diseases really in the last century, in the 20th century primarily. So starting from the late 1800s, early 1900s, we saw this, boom. And a lot of you have heard me talk about the hygiene hypothesis, but for those who the concept is new, what it is I won't get into the whole David Strawn, London School of Tropical Medicine and Hygiene. I'll just tell you that in general, the hygiene hypothesis refers to this phenomena that in parts of the world that are more developed, and I personally don't like the term hygiene because it's a little pejorative, but when it was coined, when the research began in the 1950s and the term was sort of officially adopted in the 1980s, it was referring to the fact that wealthier countries that were more developed, like North America, so Canada and the US, Northern and Western Europe, when people were wealthier, they had higher levels of hygiene in terms of more washing and bathing and so on. They were cleaner, if you will. That does not apply anymore. But what still applies is if you look at a map of the world and you look at the more developed world, so you look at, again, Western Europe, North America, et cetera, you see high levels of autoimmune disease, of diabetes and Crohn's and ulcerative colitis, et cetera. And if you look at sub-Saharan Africa, for example, Southeast Asia, the Caribbean, you see lower levels of autoimmune disease. But what's really interesting is as countries become more developed, and we've seen this in the Middle East and Saudi Arabia. I talked about my GI fellow, Hisham Salut, who was training with us at Georgetown and 20 years ago said, oh, I don't need to come to your clinic. We don't have IBD in Saudi Arabia. And now they have a clinic devoted just to IBD. So really, even in the last few decades, we've seen this tremendous spike in autoimmune diseases in countries as they become more developed. And while some of that has to do with more widespread sanitation, some things that are good, like chlorine in the water, et cetera, a lot of it is individual things like antibiotic use, et cetera, the food, what I like to call the McDonald's effect, people eating more processed fast food. And so, economic progress and development, unfortunately, do come with this downside of lifestyle and habits change. People are cooking less food at home. They're eating out. They're eating more convenient, highly processed food. They can afford to take medication more often, things like antibiotics that, of course, can be life-saving a lot of the time, but we know are also tremendously overprescribed. And the interesting thing is, in parts of the less developed world, like Mexico, for example, and parts of India, antibiotics that you require that you require a prescription for are available without a prescription over the counter. So they are quite, they're used very broadly. So we start to see this increase in autoimmune diseases. And the other interesting thing about that is if we look at countries where rates of parasitic infestation and infection are high, we see that autoimmune diseases are low. And that will lead us to some interesting discussion at the end about whether parasites could be a treatment for inflammatory bowel disease. There have been some studies using hookworm and some other things. And the idea there is that your immune system sort of maintains a lower level at keeping these parasites at bay. And so you sort of train your immune system to then not overreact to your own tissues and joints, et cetera. So there've been some interesting data on that. It's definitely not mainstream, but it's interesting that people who have these chronic parasitic infections tend to not develop autoimmune disease. And of course, parasitic infections are also a marker for typically areas of the world that are less developed in terms of access to antibiotics, et cetera. So just want you to keep that in mind when we think about these autoimmune diseases. So really, there is this sort of triad of genetic predisposition. And if we talk about inflammatory bowel disease, I mentioned on our earlier office hours that Judy Cho and her associates at University of Chicago had discovered the NOD2 gene on chromosome 16 about 20 years ago, late 90s. So maybe a little more than 20 years ago, actually, maybe closer to 25. And since then, they've described over 100 different what we call susceptibility loci, areas, chromosomal abnormalities that are associated with inflammatory bowel disease. But they are not necessarily necessary, and they are not sufficient. So even if you have these genetic abnormalities, there still needs to be an environmental trigger, typically, and that environmental trigger can be infectious. We see in about 10% of the time with inflammatory bowel disease, there is an antecedent infectious episode. So going on spring break, coming down with Montezuma's Revenge, getting Giardia on a camping trip in Colorado, not to pick on Colorado, but there is a fair amount of Giardia out there. Some sort of infectious thing. It could even be Salmonella, Campylobacter, it could be a bacterial, it could be viral, it could be parasitic, it could be fungal infection. And we think part of the mechanism there is that it creates dysbiosis, abnormalities within the microbiome that then, in combination with a genetic predisposition, can be a trigger for the disease developing. And we also know that antibiotic use is a major trigger. You've heard me talk about that article from Gut from 2014, the meta-analysis from my old stomping grounds, Mount Sinai, where they looked at thousands of kids, and they found that antibiotics early in life, in early childhood, were a major predisposing factor. And I know a couple of the folks on the call today are patients of mine. And so you probably remember way back when we first started keeping company, that's one of the questions I would ask, were you on antibiotics as a kid? It's not 100%, but it is a clear increased risk factor. Now, in terms of the genetics, if you have inflammatory bowel disease, Crohn's or ulcerative colitis, if you have Crohn's, your child is only about 6 to 9% increased likelihood of having Crohn's. But if you and your spouse both have Crohn's, then that can jump to 20 to 30%, but it's still not 100%. And so if you have a strong family history of autoimmune disease, or you yourself have autoimmune disease and you're concerned about your kids, you have to be really judicious. I mean, everybody should be judicious anyway, but you really then have to think, is this antibiotic really necessary? Is this acid blocker really necessary? Is this steroid really necessary? All these drugs that can potentially disrupt the microbiome and trigger autoimmune disease. And you also have to think, if you are somebody who's thinking about conception, you have to think about the way you're going to deliver your baby, because I talked last time about the fact that C-sections confer an increased risk of asthma, obesity, allergies, and autoimmune diseases. So I really counsel my ladies with Crohn's and ulcerative colitis about having a vaginal delivery if at all possible, and typically work with their OBGYNs to make sure that's achievable, and the same with nursing and so on. So when you have this increased risk with autoimmune disease, remember, it's not 100%, even with both parents having Crohn's, it is still only 20 to 30%, and it's significantly less with ulcerative colitis, but it is increased over the general population. And so I think in those circumstances, you really need to think about how your child is being born, what medications they're taking, how you're feeding them, those sorts of things. And the same is true for a lot of other autoimmune diseases as well. So over the years, there has been a lot of chatter, if you will, medical chatter, about what other things can trigger these diseases. And so some of the things with Crohn's disease they've looked at is toothpaste, not that. In utero exposure to measles, not that specifically. Refrigeration, definitely not that. Paratuberculosis, that causes Johne's disease in cows. And it turns out it's not, as I said last week, it's not any one thing. It is things that are disruptive to the microbiome. So I want you to think of these three circles. One is genetics, and maybe you get dealt a bad hand. One is environmental, and that is the food you eat, et cetera, the amount of antibiotics you take, and so on. And then the other is some more basic things like whether you were born vaginal or not, whether you were breastfed, et cetera. So think about how all of these things interact. And really 2 out of the 3 are pretty controllable, right? We can't do much about the genes we inherited. but we can do a lot about the medications we take, the food we eat, our exposure to nature, that sort of thing. And, when we look at autoimmune diseases now, it really is an epidemic. You only have to watch television to see the ads for the biologics to realize that we are living in the era of autoimmune diseases. So there's the issue of prevention and knowing what we know, what can we do to prevent autoimmune diseases in ourselves, in our family, in future generations. And then also, if we have an autoimmune disease, what can we do to try and get it into remission, to treat it? We don't typically talk about cure, but I think it's a matter of semantics. And I'm going to talk about this in the drug-free IBD course that hopefully you've all signed up for. Head over to digestivecenterforwellness.com or gutbliss.com to check out the course. But we're going to talk about, this idea of remission versus cure. The fact of the matter is, if your disease is clinically well controlled, meaning you don't have symptoms, if on colonoscopy or whatever imaging, there is not active disease, and let's add, the cherry on the top, you're not even on medication to control the disease, then it doesn't matter whether we say you're in deep remission or you're cured. The Crohn's, ulcerative colitis is gone. It's not active. And I usually take it a step further. So I talk about really the three forms of remission. There's clinical remission, meaning you don't have symptoms. There's endoscopic remission, meaning I do a colonoscopy on you. I look at the previously affected area. It now looks normal, which is fantastic and always a goal. And then the third, even deeper level is that when I biopsy, even microscopically on the biopsies, the pathologist is not seeing any inflammation. And that's really the trifecta. So no symptoms, looks good on colonoscopy, and the biopsies even look good. Although I remind people that if with the biopsies we see subacute inflammation, chronic inflammation, that's absolutely fine, right? And that's typically why we don't talk about cure for inflammatory bowel disease, because on biopsies on a microscopic level, we can still see some evidence of subclinical inflammation. And again, we don't typically worry about that as long as there's not active disease on the colonoscopy, like ulceration, areas of bleeding, et cetera, and as long as you're feeling well. So the same things that we think about for what cause these diseases are the things that we really need to be thinking about in terms of how we approach these diseases, how we treat them, and how we try to maintain remission. And I always want to say that I am a big fan of conventional medication. I am glad that we have these drugs available, but I am an even bigger fan of judicious use. So my goal is always to get somebody into remission with a minimal amount of medication, ideally none, but some is fine too. And it's always to start at the bottom of the pyramid with the drugs that are the safest. Typically, they're also the least efficacious, but drugs like the 5-ASAs, so that may be Pentasa, Lialda, whatever form of it you're on, azulfidine. Start with that basic layer and then work our way up to the drugs that are more potent, but also more toxic. And so it's what we call the bottom up approach, as opposed to the top down approach that a lot of the pharmaceutical companies would like you to use. But again, why expose yourself to more toxicity from a more potent drug if you don't really need it, right? So the same things that we think about in terms of achieving remission are the same factors that we think about with prevention. So it is pretty basic. We want to avoid the things that disrupt the microbiome, like antibiotics and nonsteroidals and steroids and acid blockers. And actually, there's a great article published in Nature that goes over 100 different types of medications. So those are the obvious ones, right? But antidepressants like fluoxetine, very disruptive to the microbiome, artificial sweeteners, et cetera. So if you're interested in that article, you can find it on the Gutbliss site. And that is also just a great reference because there are classes of drugs. Like, I don't think people necessarily think about antidepressants being disrupted to the microbiome, but they actually really are. So judicious use of medication, I can't say it enough, is really, really important. And when I say medication, I'm not just talking about prescription medication. I'm talking about over-the-counter. I'm talking about supplements, something that, your friend who does yoga might have told you is great, but have you checked it out yourself? Have you done the research? Because remember, for supplements, there's no FDA oversight. There's no governing body making sure that this is safe and making sure it actually does what it says it's going to do, or even checking the ingredients. It is literally the wild, wild west. So, I have to remind people that just because, they bought it at their favorite health food store or something doesn't mean it's not potentially problematic. So really judicious use of anything that you are ingesting. And that goes for the medications, over-the-counter prescriptions, supplements, and that goes for the food. There's a recent article that was published a few weeks ago that talked about emulsifiers. So emulsifiers are things like, if you think about nut milk is a great example, right? An almond milk or even an oat milk, that will naturally separate, or coconut milk. So I make coconut milk all the time. And in fact, I made my favorite gutless recipe this morning. My hair was super dry. And so I grated up some coconut and made some fresh coconut milk with a ripe avocado and a little bit of coconut oil and put it in my hair. So if you see little white things falling out of my hair, it's because I didn't strain the coconut well enough. But I make my own coconut milk because I grew up in Jamaica, and we would grate the coconut and we use coconut milk in a lot of things. We use it in our rice and beans and soups and so on. And one of the things you notice if you've ever made coconut milk, which is very simple to make, you grate the coconut and you add some water, you blend it up, you strain it, is that it separates really quickly and gets sort of rancid. So if I make coconut milk today on Tuesday, by Friday, it's even in the fridge, it's a little rancid and it's separated. You see white on top and then the heavier coconut sort of cream at the bottom. And to get it nice and creamy again, I have to mix it up. Well, you buy coconut milk in the can and it is just smooth and all milky and it seems to last a really long time. So they have emulsifiers in it. And many of those emulsifiers are the same things that they use in paint to keep the paint from separating the different pigments, right? Arguably not something we should be ingesting. Things like soy lecithin, they have things like carrageenan in there. So they are emulsifiers, there are preservatives to make the stuff shelf stable, because again, my coconut milk rancid in about 2 weeks, but yet these cans of coconut milk, 2 years, some of them the expiration date. So what this study found is that a lot of these emulsifiers that are in any kind of packaged or processed food, and again, you may think like, oh, you're buying the oat milk and it's so fantastic. And yes, some of these brands are better than others, but it is not magic. They all have some sort of emulsifier or shelf stabilizer in them. Otherwise, they really could not be lasting as long as they're lasting, even with the refrigeration. So they all have various things in them. You will not find an almond milk on the shelf where the ingredients are almonds water. It does not exist, because it would be bad if you would last a week. So this is typically stuff that you have to make yourself. If you're having a little bit here and there, I think you can probably get away with it if you're healthy. But if you have inflammatory bowel disease, I mean, the data clearly showed for Crohn's disease that a driver of disease activity were these emulsifiers that are in processed foods. So one really safe way to get around that is just to eat food that doesn't have an ingredient list, right? So you're eating an almond, you're drinking water, you're putting them together. You're eating a sweet potato, you're eating an orange, you're eating a piece of chicken, and you're not buying stuff, sort of processed, prepackaged stuff that has this long list of ingredients. Because it turns out that in somebody, again, we think about the triad, right? You're genetically susceptible. You have some environmental factors. Maybe you were on a lot of antibiotics as a kid, et cetera. You're genetically prone, and maybe you have a strong family history. And now you're ingesting a lot of these chemicals that can be really the match that lights the Crohn's fire for you, right? And the same thing. So as we think about prevention in our friends and family and loved ones and future generations, or if you're thinking about yourself and thinking about drivers of disease, and I know that that can seem so trivial, right? Compared to, well, I could just take a drug and make this go away. And you can, but of course that has some risk to it versus, and maybe you also need that, but really think about what you can do going into your pantry, going into your fridge, and really looking at the quality of food and the ingredient list and trying to get away from the food that has an ingredient. So let's see, we have a couple questions. I'm going to pause for the chat. Oh my goodness, Erin, it is so nice to meet you. Erin from South Carolina. My husband's from the wonderful state of South Carolina, from Beaufort. And you are a pediatrician with Lifestyle Medicine Fellowship, also diagnosed with IBD and remission for about 10 years on Remicade. Oh, thank you, at that Lifestyle Medicine conference. Well, Erin, it is great, great, great to have you. I think, I'm always glad to talk to everyone, but I think conventionally trained physicians who understand the importance of lifestyle medicine and the great work that that organization is doing. I'm so glad you're doing a fellowship with them. you really have a unique opportunity to really spread the word, because we know that our conventionally trained medical colleagues have one eyebrow raised. They're very skeptical about stuff, right? And they are much more likely to listen to people who are like them, in the sense that conventionally trained, did a residency, I did my GI fellowship, but I also am very open to some other ways of looking at disease and approaching disease. And I'm also open to conventional medicine. And so it seems, much more familiar to them. So for example, I have a great relationship with my colleagues at Georgetown, even though they are usually significant prescribers of these drugs, but they also have seen my patients and help take care of my patients sometimes when I'm not available, and see that, wow, this person is doing really well, primarily on diet. So this stuff must be working. And I think that's really the kind of relationship we're trying to have. And that's one of the fundamental things I'm trying to teach with the drug-free IBD course, is how to advocate for yourself with your doctor, and not to see this as this politicized, us versus them. I'm pro-vax, or you're anti-vax, or I'm a Republican, you're a Democrat. We all have the same goal. We're trying to get our disease, or our patient's disease, into remission, right? And, in a way that works, that is really creating the least amount of toxicity. And so this advocacy idea of how you talk to a doctor who may not be open to this idea of food as medicine, and how you get them to be your advocate, and how you have full transparency with them about what you're trying to do. And a lot of that is just how you talk about the plan, etc. So anyway, Erin, thank you for saying hi, and it's great to have you. Okay, so we have a question. My gastroenterologist wants a colonoscopy to identify the source of my pain and bloating, but my cardiologist believes the PrEP may trigger my AFib. What are your thoughts? So I don't know whether you have inflammatory bowel disease or not, but it's still a great question. And certainly for folks on the call who have inflammatory bowel disease, I mean, this is something I hear from patients all the time. I know I need a colonoscopy, but it always flares up my disease, so I'm really wary about getting the colonoscopy. Here's the deal. There is a way. I think the procedure itself is a higher risk of triggering your AFib than the PrEP, if you do the PrEP well. And not to say that the procedure has to. If you're well sedated and comfortable, it shouldn't. So here's the thing with the PrEP. The PrEP can induce what's called a vasovagal reaction, and that could potentially trigger your AFib. If you get to a situation with a PrEP where your bowel is really full of whatever PrEP you're taking and you're not emptying. So here's what I recommend, Patricia. Do a 2-day liquid diet instead of a 1-day liquid diet. You will definitely be in your skinny jeans. So if your colonoscopy is Thursday, instead of starting the liquid diet on Wednesday, start it on Tuesday. Cut out all the high fiber foods that I tell you to eat all the time for a few days before, maybe even a week before, right? Because fiber creates a lot of residue in the gut. And so the only time that we don't want you eating like massive kale salads is right before your colonoscopy, because it will make it a little more difficult to prep. So do a 2-day liquid prep, cut down on all the high fiber stuff, and then start the prep earlier. So for example, I tell my patients, and remember, I'm not actually giving you medical advice. This is educational, discuss it with your doctor, but I'm telling you what I do with my patients who I'm worried about the distension and triggering AFib, or patients who have had vomiting and gotten very uncomfortable, is if normally they would start the prep in the evening, I tell them start the prep at lunchtime and just go slower, lots of liquids, to make sure that they're not, accumulating a ton of the prep in their colon and unable to go. And why it's important to start it earlier, not just to give you more time so you can go a little slower, but because the GI tract, as you've heard me say, is much more active in the day than it is at night. So you want to do more of the prep earlier when your gut is more active. If you can take a little prep, walk around, stay close in case you need the bathroom, but walk around, take a little prep, walk around, that will really help stimulate peristalsis and move stuff through. So those are things that could be really helpful. And to be honest, I'm not worried about either really the prep or the colonoscopy triggering your AFib. In terms of the colonoscopy, if it does, you're monitored the whole time during the colonoscopy, and there's certainly things they can do to get you back into normal sinus rhythm. So if you need the colonoscopy, I would go ahead and not delay for that. My son has ulcerative colitis and drinks lactose-free milk. If he does not have time to make his own plant-based milk, what should he do? He's in medical school and newly diagnosed. I think we heard from you before, Anne, but it's so nice to have you, and hopefully your son will join us too. So here's the thing. If you're lactose intolerant, I don't recommend drinking lactose-free milk. I see lactose-free milk as sort of like sugar-free. It is a modified food. When you become lactose tolerant, as 75% of the world's population will become and have some degree of lactose intolerance, it's really your body telling you you're a grown-up adult. You don't need to be suckling a postpartum cow, which is kind of what you're doing when you're drinking milk. And, this is not a product that really works well for you anymore. So I think he's probably better off drinking a store-bought. First of all, good for him. He's in medical school and making his own plant-based milk. I salute him for sure. This is really impressive. But if he can't make his own, whether he's making his almond milk or cashew milk or whatever it is, I think a good quality store-bought nut milk or plant-based milk is fine. And I would do that over the lactose-free milk, because a lactose-free milk still typically is coming from cows with a lot of antibiotics in it. So I think, a little bit of something every now and again, I think is fine. But again, tell him I'm really impressed that he's doing all that, and I hope I get to meet him. All right, I've mentioned it several times, but you've mentioned it several times, cannot catch a name or spelling of the gene that increases risk for IBD. Yes, the NOD2 gene. And NOD, it's a long acronym. We don't test for it early in life because it is not predictive. It's not a test that if you test for it, we can say, yes, you're going to have inflammatory bowel disease. So it's not clinically useful that way. There is actually no predictive test that we can do and say, yes, you are going to get Crohn's. We typically will look at a family history, but not a clinically useful test to test and then say, you're at high risk and you're going to get this. The way we can, for example, with like the ApoE4 gene for Alzheimer's, where we can say you are at increased risk. We still can't say you are going to get Alzheimer's based on this, but we can calculate an increased risk based on the presence of that gene. And we can't do that with NOD2, but thanks for asking, Jennifer. From Christina, can strictures be healed with diet or supplements? On Stelara and methotrexate, and my gastroenterologist just moved to Skyrizi once it's approved for Crohn's. Strictures can be healed with diet, but it really depends on where you are. It's such a great question. If you have a very tight stricture and you've developed fistula around it, I personally do not have great success with using diet to open up that stricture and close up the fistulas. That's usually something that typically we have to rely on a biologic to get it healed and then move to diet, or surgical resection, depending on how tight the stricture is. If you have a clinically insignificant or clinically asymptomatic stricture, so in other words, on an MRI or a barium study or colonoscopy, they see a stricture, but clinically you are not obstructed, you are stable, you're not having symptoms from it. We have seen really good results with these sort of subclinical strictures opening up, but in somebody who's actually obstructed or having partial obstructions, the problem is they typically cannot tolerate the really high fiber diet that we're recommending to get them to clinically into remission because of the mechanical stricture. And I've just been editing the workbook, super excited to share it with those of you who are joining us for the drug-free IBD course. And we have, in the diet section, we wrote this whole caveat about where you start in the diet, phase 1, phase 2, phase 3, and about a sort of induction phase for people in exactly this situation. You have really active disease, or you have a clinically significant stricture or something. But, I don't like to give general advice for this situation because it's very individual specific, and it's really based on the symptoms. We always say we don't treat the image. I have a wonderful patient who's in his late 70s, and he has what we call a string sign, literally an ileum that is so narrow, it looks like a string. And he has had it looking like that for the 25 years he's been my patient, and he is absolutely fine. He had one episode of a near obstruction, which he recovered from. He insisted, he came to my office, he lay down. I have massage tables in the office. And he lay on the massage table in one of the empty exam rooms, drinking coconut water. And he's like, oh no, I can get through this. I'll be fine. This is typically not how I recommend approaching a bowel obstruction, but he's had Crohn's for 50 years. He knows his disease really well. He had been traveling, he'd been eating a little bit differently. And he hung out with us in the office for the afternoon. And sure enough, he was passing gas and pooping by the time he left. So the point of all of this is to say that you can have a stricture that looks very tight on imaging, And I'm interested in what the image shows, but I'm really interested in talking to the person and finding out symptomatically, how are they doing? And similarly, you can have somebody with pretty normal imaging, but it turns out they're having episodes of partial obstruction, and that may be because they have scar tissue. The lumen of the gut isn't actually narrower, but they have scar tissue in the area that is causing a problem, or they have abnormalities with motility, et cetera. So the symptoms are really important. So for your stricture, Christina, I would really want to know how symptomatic you are. Are you having partial obstructions or near partial obstructions? What kind of diet do you tolerate well? And, that sort of thing. So thank you for asking. Oh, thank you. I'm so glad you can attend too. Your 4-year-old was recently diagnosed with ulcerative colitis. I'm so sorry. You remove gluten and dairy from her diet, which is great. Any other recommendations? She's also on mesalamine. Is it realistic to think she could eventually wean off meds? So I have a couple things to tell you. Right now, you probably think this is all bad news, right? And I tell you, I would not wish inflammatory bowel disease on my worst enemy. But I also want to tell you that there is a silver lining, because your 4-year-old, and I don't know if it's a son or daughter, but is going to be so healthy because he or she is going to understand the connection between how they live, what they eat, their sleep, etc., and how they feel. They're going to get that feedback every day, and it is going to move them in the direction of being healthy. Maybe when they're a teenager, they'll rebel for a little bit, but I'll tell you, my patients who were diagnosed with inflammatory bowel disease at a young age are so incredible. Like, they get it. They really understand food is medicine, and they're also eat to live. They're not live to eat. They are eat to live. They want to feel well. So that is a lesson that your child is going to have. And it is, first of all, I'm so glad that he or she is only on mesalamine, which I consider a very safe drug, even in the long term, even when they're pregnant, if it's a daughter and she plans to be pregnant at some point. So mesalamine is a very safe drug. Number one. Number two, it is absolutely possible that she could wean off the mesalamine. And I think it's really important to find a doctor. Get somebody conventional who has very good experience with inflammatory bowel disease, but somebody who is open to the concept of food as medicine. So who's willing to work with you and who you can have an open and honest conversation with and say, look, I realize that mesalamine is not a big deal, but I'd love my child to not be on anything if possible. And, do you think that's a possibility? You really want to be able to have that open and honest dialogue with your child's pediatrician, pediatric gastroenterologist. So removing gluten and dairy is a good idea, but you don't want to fall into the dairy-free, gluten-free, sugar-free trap, right? So if you've removed gluten, but you're eating gluten-free pancakes and gluten-free crackers and gluten-free cookies and, gluten-free pasta, you're replacing one form of processed food for another. So ideally, if you're removing gluten, he or she is now having rice, ideally some white basmati or brown rice. They're now having sweet potato, they're having quinoa, they're having squash, they're having non-processed complex carbohydrates, right? Instead of the gluten-free version. Number one, that's an issue. And it's the same for dairy, that you're not, eating a lot of dairy-free, but highly processed foods. So really a whole foods diet. And even though I'm an adult gastroenterologist, a lot of what I'm going to talk about with the course is applicable to kids. So I hope you join us for that. Yes, bone broth can be helpful. Bone broth, again, is not magical, like acai or all these things like, oh, matcha, magical. But bone broth can be a really helpful way for you to rest your bowels. And when you have inflammatory bowel disease and there's active inflammation, we sometimes need to look for ways to deliver nutrients, but not deliver a lot of residue, a lot of, fibrous foods and so on that are going to be too stimulating for the gastrointestinal tract in the setting of a flare. So a bone broth can be very helpful in that situation. And for our induction phase for the course, it's part of what we call, you guys might be familiar with the BRAT diet, B-R-A-T, which is bananas, rice, applesauce, tea. Well, we talk about the BB brat or the B brat diet. So it's bone broth, bananas, rice, applesauce, and tea, herbal tea. These are all low fiber foods. These are not foods that we would typically use to get people into remission, but in the setting of a flare up, these can be really helpful. Planning to sign up, yay, for the course, interested in stopping Remicade. I'm very interested in helping you stop Remicade. 10 years with no symptoms or even biopsy evidence of disease. Well, one of the things, Erin, that we talk about in the course is who is a candidate, right? Because just as I am in favor of judicious use of medication, I'm also in favor of giving people good medical advice. And so if somebody's disease is really out of control, that is probably not a good time to start this regimen. So the fact that you are only on the Remicade, you have no symptoms or even biopsy evidence of disease, you're a great candidate. Mostly plant-based, you're a dream. No meat, very little dairy or processed foods. Are there other key recommendations you can add while waiting to learn details from the course? Okay, everything you possibly want to know about food is going to be there. We have, one of the PDFs, our first one was over 100 pages, so we had to actually make 3 books. So this is a very content-rich course, and you'll have this information to refer to. In the meantime, if you want to start experimenting with a little fermented food, because, Erin, it's an acquired taste, I'll tell you, like kimchi, I can't do it. Sauerkraut I like, but I like a kraut with carrots or kraut with apple, something that has a little bit sweet and crunch and tanginess maybe. So I really like this old book. It's called Jeff Cox's Book of Essential Fermentation. And in my second book, The Microbiome Solution, I have some of my favorite recipes from his book. We have the same publisher, so I was able to borrow the recipes. So I have some of the recipes from his book. There are a million videos on YouTube about how to ferment food. He has a bunch of stuff in there for, sourdough bread and cheese and wine and other things that I don't want you doing. But, his basic like kraut with apples and stuff is really great. Or if there's a very good farmer's market near you that has good quality fermented stuff, you typically don't want to buy the shelf-stable store-bought stuff just because it doesn't microbially pack the same punch. So if you want to play around with a little fermentation, I think that would be great to do in the meantime, but it sounds like you're doing so much stuff right, and I cannot wait to meet you. How do you find doctors who are open to food as medicine? Well, there are, I think, Priscilla, there's an increasing movement amongst conventionally trained physicians like myself and our very nice pediatrician from South Carolina. I'm pulling her up, Erin Brackbill, is a great example of that. So, and the reason I am sort of favor the conventionally trained who are open to food as medicine versus a naturopath is that typically a naturopathic doctor just would not have enough experience with inflammatory bowel disease. So when you're seeing a gastroenterologist or a pediatric gastroenterologist, you're seeing somebody who is familiar with the disease, is doing endoscopy and colonoscopy and looking at the disease versus somebody who's just treating symptoms, right? Because naturopaths are not gastroenterologists. They're not doing these procedures. They're not sort of intimately familiar with the intestines in somebody with inflammatory bowel disease, and they don't have training. They've not done a gastroenterology fellowship. So in order to figure out the alternative stuff that works, you've got to really be familiar with the conventional stuff. So I find that, and this is a generalization, but I can just tell you my experience with naturopaths for IBD is they don't have enough experience about the disease, and they tend to use a boatload of supplements, most of which we really don't have any evidence that works. So what I would do, Priscilla, for finding a doctor is, depending on where you are. So let's say you are in a major city. Let's say you were in DC. I would start with the academic places. So in DC, it would be places like Georgetown, GW, Howard University. There's a Hopkins presence here. And almost all the academic centers will have what they call a patient advocate person when you call. So for example, you're calling and you're saying, I want to see somebody in the GI division who focuses on IBD. And then you could ask them, is there somebody who's more integrative? So I think that's a good way to start, is start with the major medical centers, academic centers, and ask, who is the IBD person and who is a more integrative person? Sometimes that's not the same thing. There's an integrative person, there's an IBD person, they're not the same person, but you may get lucky. You can also check with your local chapter of the Crohn's and Colitis Foundation of America, the CCFA. I find the CCFA to be pretty conservative, quite frankly, and they are very, very, very well funded by the pharmaceutical industry. So I find that their bias is a little bit towards conventional therapy, but most chapters have a list of practitioners who they work with. And I find that they're a really good resource for stuff like that, for support groups, or, call up, email the local chapter and say, okay, who are the local IBD doctors who are more interested in an integrative approach? So that's another good resource. Another way to do it is ask a friend, ask somebody who has inflammatory bowel disease. Tell me about your doctor. Do you like them? That sort of thing. And, if you find a gastroenterologist, I think it's fine to call the office or email the office and ask them, is this something they do? Usually the front desk person will know and they'll tell you. So you have to do a little bit of sleuthing to figure it out. Is there a meat that is less inflammatory for IBD patients? So, it's such a good question. The issue isn't so much the meat is terrible for you, right? I mean, we do know that people who eat a high protein, low carbohydrate diet, a kind of Atkins type diet, tend to have a microbiome that favors more microbes, what we call the bibliophilia, the bile-loving microbes that help to break the meat down, but also tend to promote inflammation. But a bigger issue is that the meat crowds out the plants, right? So if half your plate or even a quarter of your plate is meat, that's a quarter of the plate where you're not having, lentils or oats or brown rice or asparagus or broccoli or anything else, or plant matter with indigestible plant fiber to feed your Faecalibacterium prausnitzii, to make your short chain fatty acids, to keep all of this stuff healthy, including your immune system. So you can tolerate small amounts of meat. And I think it's less about pork versus chicken versus rabbit versus fish versus shellfish, and more about where is the meat coming from. So ideally, this is not factory farming, right? Ideally, this is a local farmer who's raising the animals humanely, not using a lot of antibiotics or any antibiotics in their feed. And you can usually figure that out with a local butcher. If you have somebody who provides good quality meat, talk to them. Farmers markets are another great way to do that. There's a meat purveyors at our local farmers market in DuPont, and I'm very familiar with how they raise those animals. So that's a good way, is to get out of the big supermarket thing and to the more local producer and have a conversation with them about that. Okay, we have some more questions. Thoughts of digestive enzymes and any recommendations? We really don't have a specific recommendation for digestive enzymes when it comes to inflammatory bowel disease, but I have some very specific recommendations about the food, because that's where the digestive enzymes come from. So for example, papain in papaya and bromelain in pineapple are some of the things that are in meat tenderizer, and they help to break down protein, right? So rather than take a pill, a supplement, which is a very diluted form of that, and for all we know, doesn't even have any of that in it, because again, it's not tested for safety or efficacy, I really recommend that you get it from the food. And that's something we'll be covering in the course too, right? Like what the different foods are that have the different digestive enzymes in them. What do I know about fructose malabsorption? Have Crohn's, and after keeping a food diary, found out that eating fruit with fructose, you get, oh, that's so interesting, and good for you for tracking that down. Yeah, there is a threshold amount for fructose for most of us. And the interesting thing is, I find if I advise my patients to take up the fructose primarily from soda and processed foods, they can usually maintain still a little bit of fruit, because obviously that has fructose in it. But if you are finding that eating high fructose containing fruit, which would typically be a lot of the tropical fruit like mango and pineapples and stuff like that, is a problem, then that is definitely worth noting. And I just wonder if it's something other than the fructose too, but it sounds like you've figured it out. So very interesting. Thanks for sharing that. Let's see what we have on the chat. Have some more nice comments from Erin. And then a great comment from Naomi. How do I define partial obstruction? So partial obstruction really, Naomi, is a clinical diagnosis, and it is typically when there's clinical evidence that the products of digestion are either not moving through or moving through more slowly. So the typical symptoms would be nausea, abdominal pain, sometimes there's vomiting, sometimes there's constipation. And when we're talking about partial obstruction with inflammatory bowel disease, we're typically talking about people with Crohn's. If you have ulcerative colitis and you've had a surgical resection, part of your colon removed, you may have scar tissue at the anastomosis, and that can cause a partial obstruction. But partial obstructions are typically more common in Crohn's because strictures are much more common in Crohn's. And so if somebody has a history of a stricture and is experiencing these symptoms, we would typically like to get some radiographic documentation. So that could be a barium study, like a small bowel follow through where you drink some barium, or a barium enema, depending on where your disease is. It could be a CAT scan, it could be an MRI. It could even be a plain abdominal x-ray done during the time that you're having symptoms, because we like to see some sort of documentation of what's going on and where it's going on. So typically we would see a narrowed area and then a dilated area above it, kind of like a funnel, right? Or we can see air fluid levels in the small intestine where it's showing, the bowel is like this, but we see these levels showing that the stuff is just at a standstill, the products of digestion not moving through. Or sometimes we see a lack of air in the colon. So there are a lot of different X-ray signs that radiologists are very good at detecting for whether there's a partial obstruction plus the symptoms. So if you think that constipation alone is not partial obstruction, bloating alone is not partial obstruction. We typically, to say you're having a partial obstruction, we typically need some radiographic evidence that there's, some area that is partially obstructed in the bowel. Signed up for the course and would like to know psyllium husk is good for helping to control watery stool. Psyllium husk, Sylvia, can be fantastic for both things, for helping to kind of sop up more watery stool and for helping with constipation. Some people don't tolerate it because there's a lot of insoluble fiber in it and it can cause bloating in some people. You need to drink it with a lot of water. And so I always tell people, if you're using it, if you're having looser bowel movements and you're using it for that and it helps, great. But if it tends to make it worse, then, you might want to lay off. Oatmeal for a lot of my patients who have more watery stool, that can be helpful. And sometimes we use something called bentonite clay, which can bind the stool and be helpful. But you have to be careful with the bentonite clay because too much can cause severe constipation. If you have any narrowed areas, it can be problematic and it can bind up other things you're taking, like any medication, probiotics, etc. So you have to be a little bit careful how you use a bentonite clay. So I would try the psyllium. It's pretty safe. Make sure you're drinking it with enough water. And I would think about oatmeal too as a binder. There is a list on physicians, I think you mean Physician Committee for Responsible Medicine, PCRM, conventionally trained doctors who are lifestyle med trained by location. Oh, thank you for this, Erin. So I think everybody's seeing this on the chat. The American College for Lifestyle Medicine has a list of the same. So I'm a huge fan of these organizations, and particularly the Physicians Committee for Responsible Medicine. That it was founded by Dr. Neil Barnard. That is a plant-based organization. So I believe, I don't know for sure, but I think the doctors on that list will be plant-based doctors, which is fine. Neil Barnard is a prince amongst men. He's just an incredible physician and human being. And he is really in this for the right reasons, which is really to lead people to a better diet that can improve their health. In fact, he has this fantastic effort that he reached out to me on earlier, I guess the end of last year, that I'm helping with it at Georgetown, which is he is trying to get carcinogens removed from the food that they serve in hospitals. And that should seem basic, right? Like, you're in a hospital to get better. The idea that on your hospital tray would be known carcinogens, but things like bacon and sausage that have nitrates in them that are known carcinogens. He's not even saying it should be plant-based food. He's saying, could we not give people food to eat that we know causes cancer? And so he's circulating a letter to physicians to sign that letter at their local hospitals to get those foods removed. And so again, they just do such good work. And yes, Erin is corrected at PCRM. Fantastic. Linda's been on Remicade for about 18 years, would love to stop, but your doctor told you that all his patients have come off have had flare-ups. And that may be the case for him. It's certainly not the case in my practice. And that may be his experience, but it's not the universal experience. So our initial experience with getting people off Remicade was what I call the pregnant pause. I was taking my ladies off it who were pregnant, typically prior to conception, actually, because despite the fact that the drug manufacturers say, oh, this is fine, we know that Remicade gets into cord blood. They've been studies showing that it is getting through the cord, the umbilical cord to the fetus. And so what we found in those patients where we were stopping Remicade prior to them conceiving, we were seeing some flare-ups, but our rate of flare-up in those patients was 20%. 80% of the women were able to continue through the pregnancy successfully and stay off Remicade even after birth. And there were definitely some patients where we had to use steroids to get things under control. And steroids themselves have some risk, right? Even short term, they increase the risk of gestational diabetes in the mother, but the risk to the fetus of a steroid during pregnancy is much less. And so, on an individual basis, we had to work through with some of these patients in terms of when we stopped the Remicade. For some, we restarted it after nursing or after delivery. But our experience has been very different from your doctor, and maybe just different patient population, right? And again, I'm always going to recommend this with the course, that whatever you do, I am not your doctor, much as I would love to be. So you have to do this in conjunction with medical care. But again, we spend a lot of time talking about what those conversations sound like, what they look like, and how to get your doctor to get on board with what you're doing. Because that is, unfortunately, Linda, that is sort of the standard response, right? Is either, well, you're going to flare up. And so if you flare up, you can go back on it. Typically, there are a couple caveats there, depending on how long you've been off it. Or they say, well, you're going to lose your colon. I mean, there's a lot of, oh, this is danger. And again, that may be their experience, but it's not a universal experience. Okay. Did not see any info in chat. Can you repost it? Al, can you tell us what information specifically you wanted us to repost? And we'll try and get that to you. Okay. Let's see if we have some more questions. From Zuli, 49 years old and got diagnosed with mild Crohn's disease late 2016, have been on Humira since then, having major joint pain and stiffness, not to mention very lethargic. Is this normal? This is not normal, Zuli. And this could either be the disease itself, or it could be the drug. And, these are the sorts of things that we will be talking about with the course. I'll tell you, typically what we call extraintestinal manifestations of inflammatory bowel disease. So that would be things that can affect the eyes, specifically uveitis, episcleritis. It would be joint pain. We call it an arthralgia, not an arthritis, because typically there's no deformation of the joints. The joints are painful, but they're not, when we do an x-ray, the joints are still normal looking. Their skin changes, two in particular, pyoderma gangrenosum. Is one that we see most typically. And so there are a number of these extraintestinal manifestations. We can see kidney stones, but typically they would be present at the time of diagnosis. So if you weren't having joint pain and stiffness when you were diagnosed with the Crohn's in 2016, and you develop that later after you've been on the Humira for a while, there's a higher likelihood that it's from the Humira, because again, these extraintestinal manifestations are typically present at the time of diagnosis. So sounds like there'd be some sorting through with that. But joint pain and stiffness and lethargy are two fairly common side effects of some of the biologics. So it really, could be either. And again, I'm not telling you, run and stop the Humira, but that's definitely something to consider. If mesalamine has not worked with a poor processed diet, is it possible for mesalamine to then work if you change to a whole foods plant-based diet for UC? Yes, it absolutely is. Your son wants to avoid immune suppressive medication. So this is your son, the medical student, who we're all very proud of because he's in medical school and making his own nut milk. And good for him that he wants to avoid those medications. This is probably because he is a well-informed consumer being in medical school. So it is absolutely possible for something that didn't work well before when the diet wasn't great to work fantastically with a better diet, or for him to not need it at all. And so I'm so excited to meet him. I do want to say also, when you post stuff, I typically will use your name. If you don't want me to say your name, I just say your first name. Then just post it anonymously. So Christina, it appears that the studies indicate that the plant-based diets are best for a diverse microbiome, but the studies do not appear to be consistent regarding grains other than oats. What is your opinion about grains other than oats? You're absolutely right, Christina. There is, and one of the things we're going to go through, and this document was so large, we had to make it a separate PDF with all the different studies. There are way more of them now. There's a great site called Nutrition Therapy for IBD, IBD.org, and they have a lot of the studies listed on their sites too. And there's no, one specific diet, right? There's several studies using different diets. There's studies using enteral diets or studies. There's a Crohn's disease treat study. So there's not, one recognized diet that, for example, the FODMAPs diet, which is not a diet for Crohn's disease. It's not like we're doing multiple studies and reproducing the results using the same diet. The diets really vary a lot. So a lot of this is based on clinical experience. And that's why we divide our diet up into different phases. So in a maintenance phase where somebody's doing really well, we find that they can tolerate a lot more whole grains. But if somebody's more symptomatic, we do restrict some of these grains and do a slightly different modified version versus somebody is symptom-free. So if what you're asking me, other than oats, what is my opinion about grains? Most of our patients will tolerate brown rice, white basmati rice, and a very unprocessed form of quinoa pretty well. I would say people tolerate the quinoa. That's a little more iffy, and also whether people like it, but those two are typically well tolerated. When will we get the first set of the IBD course materials? Hi, Robin. We're going through it right now. We are actually contemplating, it's supposed to start next week, but we're contemplating whether we may shift that, just because I was out for about 10 days with COVID and a little behind with some of the editing. And we want to make sure we go over everything with a fine-tooth comb before we send it out to you. So you're either going to get it. So if you get it a little bit later this week, since the first one is supposed to be next Tuesday. So for example, if you send it to you tomorrow, Thursday, it's not going to give you a full week to review it, which is why we're considering pushing things back a week. But we're going to send out an email either later tonight or tomorrow about that. But to answer your question, Robin, you'll get the material a full week before the first one. Okay, I hope that answers it for you. We have a minute left. So in the last minute, I just want to tell you, please email us with, or I don't know if you're still getting the little survey, but please fill it out about, these office hours. Are they too scientific, not scientific enough? What additional subjects would you like? And let's see, I have a question from Linda before we go. Let me make sure I answer that one. Do you have to be on live to do the course? No, you don't. So for the course, we are going to use a regular Zoom, not the webinar option, so that I can see people. It's a smaller group, but you absolutely don't have to be. So you can turn your camera off. You can be anonymous. You don't have to put your name. And what we're asking is like put an initial or just a, something so that I can, if you ask a question, I can refer to you. So you could, I don't know, put Snoop Dogg. You can put whatever you want. You could use your initials. And that way we can identify if you have a question, but there's no pressure at all to have your camera on or to identify yourself. But we do want to have that option for people who do want to do that. Okay. All right. Well, I think that's all I have for today. It's always so great to see you guys, and have a wonderful week. Bye-bye.